Good evening and welcome to all the delegates here. First of all, would like to thank the team of ENT Train Workshop for organizing this panel discussion. So we are here today to discuss on the topic of a panel discussion in the next half an hour on tongue cancer. So I have here with me Dr. Akshay Gutpaje from Site Care, Dr. Samskriti, Dr. Ratan Shetty, Dr. Anand, and myself, and Dr. Rajendra. We'll be starting the discussion now. I'll just share the screen. I've just kept this very basic and info. And Ratan, Akshay, Samskruti, please feel free to modify it and change whatever you all want to add into this. I've just put some very broad questions and oh, 1 second here I am.
Good afternoon, sir.
Share. Okay, here I am. So in principle, I think through this entire next few minutes, I wanted to take us through what are the biological advances that has happened in understanding of tongue cancer and how have we bridged that with technological advances. And through taking that, maybe touch upon advances in molecular oncology, some amount of technology and cancer, choosing cancer research and cancer moonshot. Now, why are we taking up this panel today? This is just a one slider data to tell you that nothing much has happened in oral cancer in the last maybe 50, 100 years. The survival has remained the same, dismal. The number of deaths globally have been significant. India contributes to one of the largest deaths in the country and globally for oral cancers. And primary presentation is something that is late, which we are still grappling with. I mean, these are baseline things which has not changed much over the last few decades. And I think with the current trends and new advents, I think it's time to relook into what can we do to change this. Because it doesn't look like we've actually impacted on anything with the last few decades of our work. With some new drugs off late coming in, but there's still a lot to be uncovered for a common man, for a poor patient. So I'll touch upon a few things based on our timing to look at prevention, early diagnosis, treatment, and research. So I'll quickly try to see. I've picked up a few cases, and based on our time permitting, we can touch on pre-malignant lesion, early detection, molecular and genomics, NACT, and robotics. These are some of the things that I've kind of put as questions to us. So I'll start with this and I'll not follow any particular order. Ratan, Akshay, Anand, any one of you all can chip in.
Yes.
Broadly, what I wanted to show with this was, I think, this kind of a lesion in a young smoker who has a history of alcohol and classically looks like a leukoplakia. I would want each one of you all to give your few thoughts on your practice in various institutions that you all are doing. What kind of patterns do you see in practice of presentation of such kind of lesions? Number one. What do you think in this kind of a situation? How would you assess it? How would you grade it? How would you look at it? So give me a little bit of your information on this and your opinion on how would you take this up and go ahead. Can we start? Ratan, you can start and speak on this.
Yes, sir. In this case, a patient is presenting with a whitish patch on the ventral surface of the tongue and extending onto the lateral surface, also involving part of the floor of the mouth. Considering its location, it's in the ventral surface and the size of the lesion if being at least 2 square centimeter across. This is but it looks homogeneous. So clinical diagnosis would be a leukoplakia, and biopsy wise, obviously they have said that there is no there is only mild dysplasia. This is mild dysplasia. It's a low risk region, but considering the size and the site, based on various studies, especially Vanderwaal's paper, it's a high risk site. So this I would say would need excision. In my book, I would excise the tumor. If the patient does not wish for an excision, then again, the excision margins are also not like a cancer. You can do a biopsy first because this being a large lesion, I do a biopsy first, confirm it, no malignancy, then my plan becomes much more clearer. So I would excise this tumor because of the size of the lesion.
Anything specific, Akshay, anything specific that you want to add to what Ratan is saying? Anything from your thoughts?
Yeah. So if at all we have a facility for a narrowband imaging, I think in these kind of lesion, narrowband imaging can help us to do a biopsy. So yeah, I'm thinking of a situation when the patient comes to us with a white patch, a lesion like this, as Ratan told, it is a well-defined lesion. But then to take from where to take a biopsy, narrowband imaging may help in to take the site of the biopsy. In terms of how definitively we manage this lesion, I would consider more for an excision biopsy, close margin excision biopsy with the CO2 laser, and then subject it for histopathological examination. And in the counseling, I would tell them there is about 1 to 2% chance that if it turns out to be a malignancy, it would require a revision surgery. And also, I would look at the sharp tooth or anything around that area, and if there is anything, I would ask my dental colleagues to address that as well.
So Akshay, as you see in this, there is obviously he's got a clean teeth. He's not, he's maintained his hygiene well, although he's a smoker and consumes alcohol. The other interesting part which you said now, we biopsy the patient, and you said you're doing an excisional biopsy, correct?
Yeah.
But you also said that you will look at NBI to look at doing a biopsy. So are you saying that you will do an OPD biopsy first with NBI and then followed by that excisional biopsy?
Yeah, so the thing is, we would give an option to the patient. So this lesion being a large, well-defined lesion, it requires an excision biopsy. But generally, when you explain a patient for a excision biopsy, they wouldn't be ready and they would need information to decide for any operation, any general surgery operation.
Correct.
And that is a good idea. I mean, it's if you go by the standard approach, it is better to do a biopsy and then subject for any operative procedure.
So
If
here,
that,
let's say
yeah,
you've got a leukoplakia biopsy which has come as epithelial hyperplasia and dysplasia.
yeah. Despite this biopsy report, based on the clinical appearance of the lesion, I would still be advising a patient to go ahead with the excision biopsy because there is some raised lesion in the edge on the near close to the tip of the tongue, and also some area of redness around that.
Understood. So, in addition to this, at excisional biopsy, you said that I wanted you to touch upon this part about why are you all worried about counseling this patient so much? What concerns you about this lesion? It's a simple leukoplakia. So, is there anything that brings to your attention this counseling, saying that there is a 1 to 2% chance of malignancy? What is it that is taking you in that direction?
Only
The
that. Yeah. Subscriti, go ahead.
Yes, please.
habits of the patient is something that we should be worried about. So he's a smoker for 12 years and alcoholic, so they both have the synergistic effect. And being a lesion which is in the floor of the mouth, we all know it is an high risk area one. So,
Correct.
in spite of excising this lesion, we would want to counsel the patient to for a change in their lifestyle and habits, and would want to follow up the patient a bit more closely because they might be likely to develop another lesion or invasive malignancy somewhere in the oral cavity.
Yeah, so I think to some of the points which Akshay and Ratan and you have brought out. So Akshay was saying that if he has NBI, he'll do it. He'll do a pre-biopsy to get some kind of an initial idea, but that would not be mandatory. But if the patient is well counseled, and as you rightly said, this is a high risk area. High risk area has a high propensity, and tongue is one of the floor of the mouth and tongue are high risk sites wherein if you have a leukoplakia, there is a higher chance of it converting into malignancy compared to a buccal mucosa, alveolus, or a GBS region. This has a much higher area. So now with this kind of report that the pathologist gives, and oftentimes we are stuck with this kind of reports where the pathologist says that there is an hyperplasia with dysplasia. I want each one of you all to give a little thoughts to this discussion, saying here we have options of visual examination. Akshay said excisional biopsy, we have brush biopsies, we have toluene blue. That's on one side that I wanted you all to touch. And Anand, maybe you can start with you and Samskruti can add on to this. So now you have leukoplakias, you have erythroplakias, you have erythroleukoplakias, you have dysplasias. there is this thing about plasias and plakias, and that's what I have highlighted here. How do we deal with this approach of one, counseling a patient? Second is an approach towards a clinician. Today we are here dealing with a group of ENT surgeons who routinely see something like this. How do they communicate this to a patient in terms of risk assessment, in terms of risk communication? Anand, can you start with that, and then maybe Samskruti can add up to it?
Uh, so I think most often the plagias are something that the clinical, diagnosis, whereas the dysplasia and the component of plasia is something that we would see under the microscope that we decide. I think when it comes to a decision and how would you counsel the patients, I think yes, the look of the lesion, is it fitting in as leukoplakia, erythroleukoplakia? Is it heterogeneous? Is it a homogeneous lesion? Are the risk factors which the patient has? Is it at a high risk site? All of this are important decision makers for us as a clinician to consider. Should it be an excision biopsy that we plan, or should it just be a edge biopsy that we would do? Because oftentimes these are large lesions; they may not be even or same across. So a lot of times it is better to consider an excision biopsy. I think narrowband imaging and other investigations, even toluidine blue, can help us, stratify that are we likely looking at a high risk or a high grade dysplasia versus a low grade dysplasia. So if it's a low grade dysplasia overall, then we also can have an option of observing this patient with medical line of treatment. If not, if it is on the higher side, the narrowband imaging puts it at a higher risk of likely to be a high grade dysplasia, then probably an excision biopsy. So, with the margin, so that you don't cut through the disease just in case it turns out to be an in situ malignancy or a squamous cell carcinoma at a later.
So now there are two parts to this, Anand. One is access to NBI, access to something like frozen section. Let's say general most of the centers don't have these two. So what would your advice be to approach in this setting?
Sir, in that, I think most often simple, as I said, a visual examination. What are we? Is it homogeneous, heterogeneous? Are there high risk features like is it an erythroleukoplakia? The site of it and the risk habits would determine it. I think when frozen section is not an availability, we can always stage this, counsel the patient, like as Akshay said, that we will do an excision biopsy, and probably in case the report comes back to be anything concerning, he or she may have to undergo a revision surgery, which would be from a completion point of view and for definite treatment.
Samskruti, anything that you want to add to this, Samskruti?
Yes, sir. I think especially for surgeons, clinicians who are at the periphery, what they should remember is that all the adjuvants that we talk of, especially with respect to early detection, most of them, the evidence for that is low. Visual examination and biopsy is considered as the standard for oral cancer screening. So that is probably the best way for everybody to identify. And the urgence, as you, sir, rightly pointed out, availability of that is minimal, especially for clinicians who are at the peripheries. So whenever we are talking about urgence for early detection and biopsy, I think everybody should understand that the gold standard is visual examination and biopsy.
So, Samskruti, in your experience, how often do you use brush biopsy or toluidine blue?
Sir, never.
You have not been using. Akshay, Ratan, any one of you all, any experience with brush biopsies and toluidine blue?
No, sir. I have no personal experience. However, our preventive oncology department uses breast biopsy and toluidine blue for screening of oral cancers. A couple of trials going on. They do use that, but the gold standard remains biopsy, clinical exam, white light examination with biopsy. That remains the gold standard.
Good point. I think, Ratan, I think you got out a good point that when you do mass screening, healthcare workers being there, toluidine blue is something that we've heard about being used, but clinicians per se are not very fond of it. It's more of mass screening and healthcare workers and screening people who want to pick up screening at that level would want to try out toluidine blue. Akshay, anything from your side, Akshay, on experience in brush biopsy and toluidine blue?
No, sir. Agree with Ratan's.
Think another point is, I think, imprint biopsies. Those are also other simpler techniques which you use. And I think the direction that we are heading towards oral screening with applications that are, AI with machine learning algorithms, where they're able to screen and categorize or bracket a patient as a high risk one versus a low risk. I think that would be probably can be scaled up in a much easier way.
So Anand, my slide next was actually about some 10 such technologies that are actually there ready. Do you have any idea, any one of these which you have used in your practice? These are all
Sir,
readily available now.
sir, just one point, sir. Before that, just how to do a biopsy is also equally important. When you do a biopsy, it should be a wedged biopsy with an adjoining normal tissue. So incision biopsy would be a best way, especially for ENT colleagues when they do a biopsy. How to take a biopsy, I think, is also important too.
Very good point. So I think between what you all have emphasized on is it's a large non-homogeneous area. You really don't know where to take it from because the area that you take it from may not be the best representative area of the of the real molecular instability. Second point that you all are emphasizing is that the depth of it is also equally important because unless you go and get the tissue in a slightly more deeper tissue, you will not be able to show invasion. And Akshay has added that having a normal interface will also further help the pathologist kind of give some differentiation. Correct? I hope these 3 points are the important points in biopsying the specimen. Correct?
Yeah.
So now I'm just, since Anand has brought this up, I'm just sharing these 10 technologies that are there today. I want each one of your frank opinions on where do you see technology helping a clinician with better assessment, since any which ways you all are all decided on what to do. Now I'm saying that the best which Akshay answered was I have NBI, I'll use NBI. But I'm saying beyond NBI, there are 10 such top end equipment that are there today that are supposed to help you, aid you in making a better decision, to tell you where to take the biopsy form and maybe improve the accuracy. I would want each one of you all quickly, and let's start with Ratan, to tell where do you give your credence to this? How much value would you give to this?
As of now, the evidence is not very strong for each of these modalities. I would also like to add one more to this, that is confocal microscopy, where you can actually see the various layers of the mucosa. You can actually see the pathological changes that occur in real time, unlike in on a microscope. Uh, one
I'm
of
sorry I missed that. I thought I covered everything. I thought I had quite a long list. You have added one more to it.
microscopy. Basically, my colleague Dr. Arjun is working on this. So, what you can actually see, we had used on I used it in one of my patients also. You can actually see the cellular changes which occur, which you can appreciate it in real time. Unlike when you exercise the
Like
tissues.
contact endoscopy.
Yeah, contact endoscopy. It's contact endoscopy, confocal microscope. So, that is something which can be, but then again, all this has to be tested against the gold standard, which is biopsy. And most of these are for screening actually. The chemiluminescence, the tissue fluorescence imaging, that is the well scope. The Again, the biomarker is also for screening. DNA ploidy analysis, you need a biopsy for that. And lab on chip is also for screening. All this has to be tested for screening. It has shown some sensitivity, but yes, the gold standard, you can use this for screening as a screening tool, but the biopsy remains the gold standard for
Very good.
diagnosing the
Good
patient.
point. Akshay, Anand, anyone, and Samskruti, you can add up to this. Anything. I'm just talking about a lot of technology being discussed in oral cancer for early detection. Just your frank opinion as clinicians, where do you see this going? Akshay, you can take it.
Which most likely will get implemented in the screening. So I personally don't have experience, but definitely it is in times to come. This will be tested and tried for mass screening programs.
Anand, anything from your side and Samskriti?
Right. I think a few of them will come, across, but I think a lot of them are also, if not fully invasive, at least a little bit invasive, which may be very close to doing an excision. So even the turnaround time for a lot of them are not real time. Some of them will take time. So, considering that, I think in like whatever people have been proposing at a mass scale and also doing these, when you're using it for a screening purposes, I think you may need more equipments and all of it. So, considering that mobile-based applications which are now becoming popular, I think will be the way forward, and these will remain as a list of things which would probably aid in diagnosis, but I don't think at a mass level these can be implemented.
Okay, Samskriti, anything to add to this?
Yes, these advances are here to stay. Mainly because when we look at the papers who have where biopsy was used as gold standard, something that they found very difficult, and that is an on-ground difficulty also, because a doctor or an experienced doctor cannot go and visually inspect the lesion, take a biopsy. That is not possible. So
Correct.
the technology has come in mainly because they want to triage the patient. So this
Absolutely.
way, no matter who goes and examines the patient, they have an objective way of triaging the patient. So there is no subjective bias in understanding the lesion. And these technology tomorrow is definitely here to stay. But more than detecting cancer, they might help us in triaging and identifying high risk patients. So they can be seen by a clinician, and probably that is probably how the clinical trials might be designed tomorrow.
Perfect. I think Samskriti, you summed it up very beautifully. I like the word triage. See, I think most of what this is again to our participants audience. I think what the panelists have summarized for you is there's a lot of technology coming up. This technology may not classically be for a clinician, as how Akshay said, that it's straightforward, go inside, do a biopsy, plan the thing. But the overall planning here is to look at screening, whether it's a mass level or a large level of screening, which is done by healthcare workers or by the junior staff, which improves your overall precision to picking up high risk cases, triaging the patient so that we don't miss out on the real bad lesions which are going to turn to malignancy. And I think this could be a good solution in dental clinics, in screening centers. These technologies could play a role in the future. We are not sure as of now, but I think till today we've not found this in our clinics, at least in most of our centers where all of us are working currently. So that's the reality of it. It's currently there in trial mode in studies, but not as a part of the ingrained clinical practice. And that's the reality for us in India, that you have rather a district hospital take a cautery, excise the entire lesion, send it for a biopsy, and then refer it to a higher center if it's malignant, or directly refer it to a higher center if you're not trained on doing something like this. Because as the panelist said, high risk sites can be may leave you with a malignancy positive. So it's very important to counsel this patient so that if they want to go in for a higher center, they should take that opinion. So with that, I think we've just summed up some part of it to say that we are going to look at wide local excision. An excisional biopsy. Then, if there is a malignancy, to go for a wide local excision. How many of you all would look at imaging? I just wanted to cover imaging in this. Other than NBI, Akshay, anything else that you'd want to image in this?
Imaging, but if there is a little bit suspicion, maybe at a max an ultrasound of the neck, nothing more than that.
Okay, but you wouldn't.
But not a routine. Imaging is not done as a routine for a precancerous lesion.
So you wouldn't do an MRI or a CT scan definitely in this kind of cases, correct?
Yeah.
Perfect. So this was an excisional biopsy that was done. This patient's histopathology came as SCC and the margin was 0.1 mm. Now they didn't have frozen section facility. So I would want each one of you all to tell me, in these kind of situations, what could we have done to prevent this? What are the next steps for us? Just quickly, some few lines.
Uh,
Ratan, yeah, go on.
Something which we could have avoided, like Dr. Akshay and Dr. Samskriti also mentioned that. So when you exercise with negative margins, and your negative margins may not be a centimeter or a centimeter and a half, like you would do for a conventional oral cancer, but at least aim for about 6 to 7 millimeter margins grossly. When it shrinks, it becomes 4 to 5 mm. Even 4 mm margin would be acceptable in this case, but not 0.1 mm margins. So when you exercise, one should be trained how to exercise it. And secondly, uh, experience matters. Exercise only the ones which uh, you think are this one. If it is looking dangerous looking, if it is a non-homogeneous, you err on the side of caution and do a excision with good margins rather than.
Ratan, how much of importance would you give for having a frozen section in your OT when you do such procedures?
So I personally do not use frozen section as much as others. So in my practice, frozen section is only when I'm not very sure of margins. One gross examination, if I think the margins are close, yes. But in this case, what I would do is I'd access with margins. For
Sorry,
about
I would paraphrase it and say for diagnosis, not for margin. Would you use this for diagnosis?
Okay. For diagnosis, yes, in not in uh, uh, potentially malignant disorders, I do use frozen section in cases like this to see whether we should address the neck or not. We'll know how thick is the tumor and all that. So I do use frozen section for such tumors, and frozen section will tell us again the margin status, and we could have avoided having 0.1 mm margins. And again, if it is a invasive malignancy, we could have taken a call on whether to address the neck or not. And the evidence is saying that we should address the neck. The neck addressal is an entirely different topic altogether. So I would use frozen section in a case like this if I have access to it.
Akshay, anything from your side?
I think, yeah, frozen section is definitely very useful in these kind of situation. Additionally, if it's someone practitioner outside, it would be good to have a photograph of the lesion taken and then put it onto the discharge summary. So later it may be helpful to identify, kind of locate the lesion when you have to go for a re-excision or something.
Mapping of it.
Mapping of the tumor.
Mapping, yeah.
Very relevant point. Very relevant point. Anything else to add, Anand? Samskriti, anything that you all both want to add?
No, sir, I think most of it was covered.
I think the two important points that I think the panelists have brought out here is frozen section, if it is available, could be used for two purposes. One is for the diagnosis per se, because you will get multiple sections and you will be able to see some amount of, if there is an invasion, if there is a basement membrane erosion that is going to be present. The second I think they are talking about is margin. These two are things that the panelists have emphasized on. And I think frozen section, if available, would be desirable for us to use. But if it is not available, then in such scenarios, you need to take the patient back. And as Akshay said, if you have a prior mapping of it, because many of them come after a couple of weeks, then you would have lost track and you would have mucosalized. In such cases, you'll have to go wider because you don't know really where the actual edge of the lesion was. So that would be a good take-home message for us in pre-malignant lesions of the tongue, not to take them lightly. Highlighting points are that do not, they are high risk category. You will end up with a scenario like this if you are casual. Counseling of the patient is paramount in such cases. Explain to them that there is a likelihood of malignancy and addressing the neck. And thereafter, frozen section, if available, should be used for diagnosis as well as margin mapping. And thereafter, the final histopathology is also equally important because in about 5-10% of the patients, the frozen section may not be fully accurate. So with that, I think I'll just quickly move to the next question. And I'll just add a few points for the sake of our audience update. it's very important for you, as our panelists have said, to differentiate leukoplakia from dysplasias. It's important to know that only about 5 to 25% of the leukoplakias will have dysplasias. Not all the persons with leukoplakia will have dysplasias. And moreover, if you see, dysplasia is present more in non-homogeneous than in homogeneous, and it's a marker of molecular instability. What's interesting is that 36% of the dysplasias progress to squamous cell carcinoma, which means that more than two-thirds don't. So just because there is dysplasia doesn't mean that you'll have malignancy. So do not end up scaring the patient that dysplasia is malignancy, because dysplasia is a molecular instability that keeps you prone for malignancy. And that's a simple understanding that you should gather from the word dysplasia. And also, if a patient asks you that if I do not have dysplasia, will I have cancer? Yes, 16% of the leukoplakias without having dysplasias may move towards cancer. So these are simple, basic facts that will help you in your counseling of a day-to-day routine patient. So these are some of the facts that we know, that the annual transformation rate can be as much as that of 38%. So vigilance in them is very important. Counseling them to quit tobacco is important, and surgery remains the mainstay. I've just elaborated here that there is no role for any kind of antioxidants to be used for long term or steroids to be used. I'll quickly, I think I'll skip this because because of a lack of time, but I'll move towards the other interesting topic which I thought I should touch in this setting. Sorry. I'll skip the screening part because we've discussed quite a lot on pre-malignant. I wanted to touch a little bit more on the future aspects of things like genomics, proteomics, metabolomics, and gene-side medicine. So we are now on bedside medicine to now talking a lot on gene-side medicine. Every center is doing a lot of work on genomics. So I'll just, in the next few minutes, take the panelists and ask their opinion on where do they stand on the understanding of genomics for tongue cancers. So we have a 49-year-old gentleman, T2 lesion, operated twice, came thrice with the third time with a stage 4 lesion, repeated recurrence. I'm talking about an old case, near total glossectomy done, and after that an ALT flap done, reconstructed. This was the lesion. It was a pull-through procedure. Now, after doing this entire procedure, the final report came that he had an ATM mutation, he had a P53 mutation, and this was the list of some of the genomic mutations the patient had. I'll open it up for discussions to tell on what do you think is the current role for comprehensive genomics in the current scenario, in your practice, in your experience, and where do you see the future hold for it? We have, I think, about 10 minutes left to sum this up. So I'll just want each one of you all to take them, the audience and the participants, to a little bit of the future, because they have to be future ready for understanding what the future and technologies hold for us. Ratan, we can start with you, Ratan.
Yes, sir. This is something which, see, things haven't changed over the years, that has been mentioned. So this is something which needs to be worked upon, and you can better prognosticate the patient. We know what we are dealing with. So the cancer is actually a cellular disease. It's and we are treating only the phenotype, not the genotype. And I know as of now, there is not much evidence for treating the genotype of the head and neck cancer, because the mutations that are occurring in head and neck, especially oral cancer, that is heterogeneous. So this is something NGS, doing NGS on the patient tumor is something which can get us some targets which are driver mutations, or if not driver mutation, we know actually why the patient is doing badly. So what are the genomic changes which are occurring, which is causing the patient to have multiple recurrences, and you, even when the patient cannot be, you can actually prognosticate the patient.
And Ratan, tell me, where do you see from your centers the future of precision medicine using genomics?
Yes, this is going
How
to be the
far are we
future.
from that?
And if somebody says that, sorry, I am fine. Yeah, if somebody says that precision medicine is not going to have a future in the near future, then they are living under a rock. Actually, this is going to be the future of medicine in another 10 years. If you do not know how to work up a patient with regard to this, then we will be losing out on a lot of things. I mean, uh, most of the survival benefits that you have got are in the last 10 years. Even in oral cancer, they say that for a long time there was no survival benefit. But you are seeing survival benefit because the people are taking into account the molecular uh, markers that are occurring. And I think Vishal sir, you are at the forefront of this research, and you are a better person to explain this than me.
Yeah, I've been only asked to ask questions today, so I'm. So we'll go to Akshay now. Akshay, what's your opinion on this?
Yeah.
On genomic
So, with
medicine?
regards to genomic landscape in oncology, there have been promising treatment interventions in other sites like melanoma, breast, colon, and other things. Whereas head and neck, there is definitely promise, and we need to embrace this. We need to look into this, and so that in future we will have established like targeted treatment when we're dealing with these situations.
Anand, you want to add something to this?
Yes, sir. I think we are probably when it comes to head and neck, probably just the start of this journey. Currently, probably the limitations are our understanding of the genetics itself. And we are not doing it routinely. We're not doing it more. I think once we start doing more, probably our understanding would also get better. But yeah, at this point it is more from it hasn't reached a point where it can definitely be therapeutic in each and every case. But yes, from a point of prognostication, yes, can help us, like, would more than including new treatments, it could help us avoid certain treatments which probably may not really be beneficial to this understanding resistance mechanisms, what could have possibly been the reason the patient had a recurrence. It may help us understand that. But I think at this stage, we are not in a stage wherein, probably right at the start, we do the genomics and we can alter the entire course of, the outcomes.
Yeah. Samskruti, anything to add? I'm just showing the landscape of where things are going for our audience. This is, I think, as rightly pointed out by Ratan and Akshay also, that I think we need to embrace this. Today, breast cancers, lung cancer, colon cancers, slowly all each cancers, they are able to pick up signatures. And I'm thinking that head and neck has been lagging behind because I think it's not a Western issue. So somewhere India has to come up with some of its own specific answers for head and neck cancers, and I'm sure coming years will with institutes like Tata, Kidwai, all of this, we should be able to show some substantial collaboration to give direction. So now, Samskruti, can you add some more to what your practice looks like with genomics?
Right now, practice wise, genomics is not something that I'm using routinely. But I think the very first sentence that you have used, sir, in the presentation, that the outcomes in head and neck has not changed over the decades. I think that itself is a red alert for most of us, that TNM and clinical and pathological features is not actually telling us what the disease is. So genomics will definitely, like how we've had clinical nomograms, tomorrow we will have molecular nomograms. So that will, guide us in deciding the treatment, whether we push the patient for neoadjuvant chemo or surgery. That way, at every point in our practice, we will have to use molecular markers and genomics tomorrow. But right now, in my practice, definitely no, sir.
So, just for the sake of the audience, from what we've discussed now today, there are various panels, various companies are doing it. MedGenome is doing it, Strand is doing it, HCG is doing it. There are various collaborators. There are various centers doing genomics, and I think, like the panelists have rightly pointed out, we don't have a full-fledged, complete value for the cost-benefit ratio that we are doing. Today, I think there are a whole lot of these. I'm not going to skip this, but just to tell you, this is how a report looks like: a tier 1, tier 2, tier 3, tier 4 response in variants. Tier 1 response is what we today say as variants of strong clinical significance, which can predict the response or resistance to therapy, FDA approved drugs that are there. Tier 2 is when variants of potential clinical significance are there. Tier 3 is variants of unknown significance, and Tier 4 is variants with uncertain therapeutic benefits. So today in head and neck, what we are picking up is, as you see in this report, a lot of Tier 2, not Tier 1. That is where we are. And this is just an example to show the audience that genomic reports that you see classically today are in head and neck, specifically emphasizing Tier 2, which is why I think Anand, Akshay, and Ratan and Samskruti were saying and emphasizing prognostically, you can talk about it, saying it's a more aggressive cancer. Treatment decision wise, you may not be able to take a direction on this. And I think there is a lot of work going on in the future for something like this that can come up. And I want you all to look into this slide and appreciate that one report that is looking at this. Now, this is showing how non-homogeneous treatment patterns can change when we look at the cancer genomically. This is for our audience to say that a tumor which was a tongue cancer was behaving like a breast cancer or a colorectal cancer or a hematological cancer based on genotypes. What Ratan said, the phenotype is what we've been treating, but maybe the genotype has a different signature compared to the phenotype. So it's very, very interesting for us in the coming years that what we treat as a tongue cancer could be a conglomerate of various other non-genomic, non-homogeneous genomic signatures of other subsites, which means that you may have treatments outside the purview of your subsite. And I think that is where the future of oncology will be in the coming years. So I'll stop at this and see that yes, oncology there is going to be a future for genomics. I think they are tightly bound. They are going to work together. With this, I think I'll open it up for any discussions or any other questions from the panelists if you feel it's relevant to share with the audience. So we've covered our 35 minutes, so we can open up for any relevant messages that you want to give. I think we'll start with Ratan. You can just give a short message to the audience related to tongue cancers pertinent to this panel discussion.
Yeah. So you have summarized most of it, sir. The tongue cancer, as we know, is a devastating disease because in our practice, 70% of our cases are advanced tumors, and the surgery that we do are major glossectomies for most of the cases. So it leads to a lot of problems. Patient is not able to swallow, not able to pronounce his words properly, and he'll be dependent on the tube for a long time. And a very small proportion of patients actually start swallowing through their mouth. That would be around 20% in our series. So following major glossectomy, what I'm talking about is type 4 and type 5 cancer. So we should emphasize on early detection, and most of the detection tools that were summarized in your presentation can be used for early detection and can be sent to the patient can be referred to the treating physicians who would be able to, because the survival is significantly different for an early disease versus a advanced disease. If you come to the advanced tongue cancers, the survival is around 30 to 40%, whereas in early disease it is around 80 to 90% based on various series.
Sure.
And coming to molecular markers, yes, as of now there is no role. It's only in the research setting, and immunotherapy has a role, especially in recurrent metastatic setting, not much role in neoadjuvant setting. There are trials running on that. We are not discussed regarding neoadjuvant chemotherapy, but because the evidence is not very strong towards it. But yes, all these things, the immunotherapy markers, the molecular changes, all have a role. But as of now, the gold standard remains surgery followed by adjuvant treatment for tongue cancer with rehabilitation, which should not be ignored. So rehabilitation, even consider prehabilitation so that the patient outcomes will be better if in the post-op period. If patient has prehabilitation, then the rehabilitation in the post-op also becomes easier for the patient.
Thank you. Akshay, for your concluding points. Akshay, can you hear?
Yes, sir. So I think as a oral cavity cancer, there is an opportunity to cure if done properly first time. So evaluate properly. And the first chance, if at all you get it, you do it right. You collaborate with your oncology colleagues to, because always the first chance is the best chance. You get a wide excision, get adequate clearance of the lymph nodes, and do an appropriate reconstruction. And at this point, I mean, that is the one thing we as together as a ENT community can do the right thing first time, and that gives the best result.
Thank you. Anand?
I mean, I would just want to, add up to what Akshay sir just told. I think early detection remains the key to, help. So focus should also be on early detection, creating awareness. Second, I think is we see quite a lot of them who become advanced because of a missed diagnosis or a missed evaluation. I think whenever in doubt, it may be better to seek help or, ask for help, rather than just trying to micromanage things and then lead to a poorer outcome. I think emphasis should also be on these molecular markers, so that before a full-fledged disease starts, can we detect it early? I think that would be the most relevant thing for a patient.
Thank you. And Samskruti, your final words.
Sir, in tongue cancer, we should remember that treatment, be it along with surgery and radiotherapy, is quite morbid. And as Ratan rightly pointed out, rehabilitation, and also psychological support, patient family needs to be counseled, the patient needs to be counseled. So especially with regard to tongue cancer, when swallowing, speech, everything is going to be affected, it is extremely important that we have to factor in even other the circles around the patient. So the patient has to be treated holistically, especially when it comes to tongue cancer.
Thank you. Thank you. Again, I think I would like to thank all our panelists, Dr. Ratan, Dr. Akshay, Anand, Samskruti, and Dr. Rajendra for allowing us to have this short, simple session on in the ENT Train workshop. I think the intent of this workshop, of this particular panel, was not to kind of get into the exhaustive discussion of tongue cancer, which is an endless a day's discussion, I think. We just wanted to touch in some basic points to stimulate the thinking among the young trainees, doctors, junior consultants, and students, that tongue cancer is evolving in its understanding and biology. And that's why I put two scenarios, one of technology, one of high-end genomics and other things, to understand how biological interpretations are changing. So I would say that if you want to be future ready, we will be moving towards precision medicine, and tongue cancer is something that we'll need to solve from India. So for youngsters who are interested in research, I think this is a very important area, a neglected area, which the USA or Europe won't solve for us. We will need to solve this for ourselves. And it's worthwhile that we pursue our research more in multidimensional, clinical, pathological, imaging, and even genomically, to find new answers to solve a preventable problem, ultimately tobacco control being the answer. But I think as a summary, this is how we would be happy to take more questions, and you can reach out to the panelists directly through your email to clarify your doubts. We'll be happy to answer all of them. Again, thank you for this opportunity. Thank you all.
Thank you, sir, and thank you all the panelists.
Bye-bye.
Thank you.
Thank you, sir.
Thank you very much, sir, for your precious time.